Okay, today we are talking about mobility, and the concept of mobility is defined in your book, but I want to um, bring one perspective of why mobility is important, why you have to look at it. Think of mobility and immobility. Where do I stand as a human being in self-care? Can I do my activities of daily living if I can't be moving or I can't uh, be independent? And if I'm not independent in my mobility, going to the bathroom on my own, what is my self-worth? How do I feel about my like my psyche? Like how is that going to affect me psychosocially? So these things keep in mind, in addition to the pathophysiological things we're going to talk about. So our class learning objectives for this module is to be able to understand the key terms that are related to the concept of mobility and consequently understand that concept when there is impairment, when there is immobility, what are the physiological and psychosocial um, elements are associated with that. But before this, know what puts a person at risk factor for impaired mobility, and then what's the consequences of immobility on every level, in every system in the body, and what can you do as a nurse? What are some of your roles? And you see that this is more of there's so much collaboration in this role, but there's also safety considerations that we will talk about. So your book defines mobility as a state of or quality of being mobile or movable. But other terms used in conjunction is like lack of mobility, disuse syndrome. And what's happening here is that the muscles, when they're not used, they tend to be deconditioned and they look uh, due to the lack of movement, they will shrink and atrophy. So mobility as a concept ranges again on a continuum. You can be fully mobile to partially mobile to which we refer to as impaired mobility to complete immobility, but that can be on a micro or macro. What do we mean by micro is that a particular part of the body may be immobile or the whole body can be immobile. Also, sometimes one part is immobile, but the rest of the body is mobile, such as when your leg is in a cast, and that also could be only temporary. But nonetheless, the concept map of mobility falls on the bigger uh, core concept of safety, and what we need to have is and you learn why it's under safety. So for a person to be mobile, what are the antecedents? Like what is prerequisite for being mobile? We need to have the energy, adequate energy, meaning that we need to be meeting the nutritional needs, rest, sleep. We need to have sufficient muscle strength, and so in order to move, we need to have the coordination. We need to have um, we need to be free from any underlying musculoskeletal problems. So a person with a sprain or a strain can become immobile. Um, a person with a neuromuscular disorders can be immobile. Also joints, if the patient has a knee problem, a hip problem, then their mobility is going to be affected. And when we talk about neuro, also other than the effect of neuro on musculoskeletal, we talk about coordination, gait. How is their gait? Is their gait stable? And that's where I talked about safety. That's where you remember safety and what is safety gonna be um, in when the patient is immobile. So so when we look at um, mobility. We're looking also at can that patient do the fine movement, or they're just able to do gross movement? Do they have the dexterity? Are they able to feed themselves? They able to walk and in a steady, fast or a slow pace, wherever, but the pace is steady and they can they're not gonna trip, they're not gonna fall. But certainly also age and cognition is gonna play a role in mobility, and we'll talk about those risk factors in a minute. So then what is the outcome of having an adequate um, mobility? If we look at the positive end of it, we can say the person can be independent, they can be physically active. But if we look at the negative consequences of immobility, we're going to see constipation, we're going to see um, skin breakdown, we're going to see contractures, we're going to see dyspnea on exertion, we're going to see swelling, and especially in the lower extremity, we're going to see also that low self-esteem we talked about. So let's talk about the body part and the systems that will enable or disable the ability of being fully mobile. So we have to have a refresher on the musculoskeletal system, the anatomy and physiology of that. So the bones of the skeletal system are the framework for the attachment of muscles, tendons, and ligaments. And what does the skeletal system do? It's there to protect the soft tissues and to maintain them in their proper position and give that stability to the body, maintain the body shape. And you know, bones is where we have the reservoir for calcium. It's where we have the hematopoietic processes where blood cells are formed. But also the important thing in mobility we're thinking here is that coordinated movement that between the skeleton and the tendons and ligaments and how joints are lubricated. It will be the key for our coordinated movements. And what do we need to remember in here? What we're focusing what we're focusing on here is that the optimal mobility is dependent on bones, joints, articular cartilages, tendons, ligaments, skeletal muscle, how muscles are contracting, and how the neurological system is working to coordinate those complex processes of nerve and neuromotor functioning. You know, the signals are they being sent and they're being sensed. Is there an ability for the brain to interpret those signals? So you'll see that, you know, a person with a neurological damage, they're going to have musculoskeletal dysfunction or immobility. And the brain and the spinal cord and the peripheral nerves, they all work uh, to orchestrate the musculoskeletal movement. And then you remember the cerebellum, that's where the coordination equilibrium happens. So, and we're not going to dig into the bones and how bones are formed and all those hormones and how joints and muscles um, can which what are the diseases of those um, parts of the skeletal system. You have to come forward with your anatomy and physiology and pathophysiology into this course. But we're talking now about immobility. We have to talk about it as such. When you cover, for example, fractures in another course, then that's where you dig more into bones, and you'll talk about spinal cord injury in another med surgeon. That's where you dig in also more. So There are multiple conditions that will affect mobility, and we talked about it. Whether it's a pure neurologic, it's going to affect musculoskeletal. If it's only musculoskeletal, it will affect musculoskeletal. But for the most part, they will have also those neuromuscular conditions, and we'll talk about some examples if you know somebody, and when we're in class, we'll discuss this in more detail. So risk factors, we always talk about risk factors. I want you to come forward into the class discussion knowing who is at risk, what could be a risk for impaired mobility. So we have to talk about this more and an interactive kind of discussion. And I want you to bring to the table your knowledge. So again, who's at greatest risk? Why older population? What contributes to that risk? I want you to, uh, if you're even if you don't attend the class, pause, go into your book, look at that, see why certain population, why these older adults are at greatest risk for immobility. Does it come with age? Is age contributing to the pathophysiology, or is it something that is superimposed on the fact that a person is older? So make sure you come to class ready to discuss this. So to be able to recognize the compromised mobility on an individual, you have to have some tools in your toolbox. One of them is your ability to do the health assessment, and that you can get from your health assessment course. Of course, you come forward with your anatomy and physiology, but then you're gonna see, other than in the health assessment course, in your lab, you're doing this passive range of motion for your individual patient, and you know, and you are able to differentiate and recognize who is in need of passive range of motion and who can do their own active range of motion. So which patient you need to help to the bed, and from the chair to the bed, and from the bed to the chair, which patient you need to use lifting tools to help you with helping them mobilize, which patient you need to assist to go to the bathroom, which patient can independently go to the bathroom. These are things you do, and you identify in your plan of care when you're assessing your patient. So now we're going into the assessment of those elements of musculoskeletal system. So first we're gonna look at the past medical history, family history. Certainly we're gonna look at current medications. Well, if your patient is taking pain medications, if they're taking blood pressure medications, and that could put them at risk for fall. That could potentially be a mobility issue. And then lifestyle behaviors. Do they have sedentary lifestyle? What occupation do they do? Is there anything that's kind of in social environment impair their cognition, such as alcohol, drug use? Do they have a specific problem, such as a sprained ankle? So you need to look at those specific problem-based history. Some symptoms you will see with altered mobility, and we're looking at each body system in details, but in general, pain, decreased range of motion, risk for falls, fatigue, lack of coordination, gait problem, lack of balance, their decreased ability to take care of their own areas, like we spoke earlier in the PowerPoint. Again, we're talking about diagnostic testing as a method to help um, diagnose what's going wrong. So you'll see that there may have radiographic tests. X-ray is a very good way to detect if a bone is broken. We look more with CT scan and bone scan on and the density of the bones. We're looking for when we go to those bone scan and densities. We're looking more at osteoporosis. Um, Sometimes you'll have with the musculoskeletal EMGs that looks at the electrical stimulation and how the um, contraction is happening. You see that done a lot to identify a muscular problem. Then also you have lab tests and lab uh, testing is very specific in musculoskeletal. You'll see that the CK, CKMB, CKMM, and all these elements will identify any enzymes that are released from certain muscles for certain specific conditions such as multiple sclerosis, myasthenia gravis, all these conditions, they have their own very specific tests according based on assessment and preliminary diagnostics. They'll go and do further testing for these patients. So our nursing interventions, and like I said earlier, we have a lot of collaboration in this concept. PT, OT are going to be key disciplines that we will collaborate with. But why we care? Why do we care about whether the patient is immobile? And you see that the complications of immobility will put the patient at secondary disabilities, and the longer the person is immobilized, the greater the risk for development of those disabilities. And we know that the entire body will be affected by decreased mobility. Each system is gonna be affected. So then you look at your those primary, secondary, tertiary preventions. So we'll talk about those next. So differentiating here between my patient who's on complete bed rest versus a person that can do some normal activity, and again, we're basing those clinical management based on how can we impact the outcome for this patient. So the primary prevention is, of course, avoiding that problem. So think of those educational activities that you're going to do as a community health nurse in preventing motor vehicle accidents, in teaching how new moms on how to make the car seat secure. Again, here we're looking not only at prevention of any immobility issue, we're also looking at optimizing the physical activity, especially with older generation, where we know if they don't have the muscle mass, then they're going to be more at risk for falling. So, encouraging exercising, encouraging optimum nutrition, and like you go in the community, you go to a home of the patient's home, and you teach them how to make the home protected against injury. So no rugs that are gonna they're gonna trip on, no cluttering inside the house. These are all primary prevention. You're trying to prevent any falls, because once a person falls, they're gonna be immobile. Once they're immobile or limited mobility, they're gonna have the vicious cycle starting with all the systems becoming compromised. So this is a good time to think about all those assistive devices that we can use to optimize, people who have some gait problems, some coordination problems, some mobility problems. How can we use those assistive devices, canes, walkers, and learn how to learn them so we can be able to optimally teach our patients how to use them and thus keeping them safe. You're gonna see that you're gonna work with this a lot as a nurse. Um, so then in fall prevention measures, you're gonna see that screening. The first thing you're gonna learn when you screen for fall, that some institutions use the Morse fall risk scale, and then when they do that, they're looking at the elements that put the person at risk for fall. So then we talked about screening and how screening is more in the secondary prevention. So when you teach your patient of how to remove the clutter, you're preventing that fall from the beginning. Where when you screen who's at more at risk for fall, you're preventing the fall. And so some of the screening tools, like I said, is more for risk. You'll find multiple tools used, but that's, if you go to Bowman, that's what they're gonna be using. Also, who gets screened for osteoporosis? What's the national guideline for osteoporosis? So who should be screened for osteoporosis? When do we start screening? All these are knowledge you bring forward or you have to become familiar with. So when we talk about collaborative interventions, so you're going to see that there are numerous interventions that we do for people with limited mobility, and based on what they come, their condition, their diagnosis, we will see that we have to be partnered with those. Other disciplines and not only partner with other disciplines in what we do to help them, but also use multiple levels of interventions. You'll see exercises, you'll see drugs, pharmacological agents being used, you may see surgical interventions, and you may see assistive devices or immobilization tools. So when we're caring at a patient for who has um, mobility, you see that we have to be helping them move, and there are national standards for safe patient handling and mobility. The American Nurses Association has released those to improve the safety of the patient, but not only the safety of the patient. We have you in mind. You have the healthcare workers, so that ergonomics, the way you carry it, how you, if a patient is at certain weight, you have to get somebody to assist you with the moving or mobilizing this patient, and it goes incremental. If the weight is such, then two of you is not enough, and so these are all things that you're gonna learn. You have to be cognizant that you're not only keeping your patient safe, you need to stay safe yourself. And one overarching principle we need to keep in our mindset as an interdisciplinary team is early mobility. And there are challenges, there are barriers for that, but we have to know that um, we need to get going with early mobility because it's going to be the number one, the key factor in preventing complication in getting the patient to their optimum mobility level as soon as possible. So some of the nursing interventions that are incorporated and built in and goes without saying for the care of any immobilized patient, regardless of where they come from, um, is having that progressive mobility. So we gradually increase the activities, and so we can go from positioning, turning. There are beds that do that continuous rotation, to range of motion exercises, to tilt table, to chair position, to dangling, and to ambulation. And when we position the patient, we need to be cognizant of appropriately aligning their body and appropriately aligning our body. And so we need to make sure that we're not creating injury with our mobility for that patient. We're looking at preventing pulmonary complications. So you'll see that you put pillows to help align the patient body when you're putting in that Sims position. You also need to reposition the patient every 2 hours, and then you hear do the percussions, the deep breathing and coughing. You also are cognizant of the possibility of skin breakdown. So that's also why you're positioning the patient frequently, making sure that when you're positioning the patient, if they're wet, you clean them and get them dry, but also not to put them for a prolonged period over bony promises, because that will cause pressure and pressure injury. And nutrition is here. We know we're gonna work our way on providing adequate dietary intake, but you'll see that these patients who are immobile might get also nutritional supplementation. Vitamin D and calcium is gonna be very essential with helping and prevention of osteoporosis. So exercise therapy, there are specific exercise therapy interventions that need to be planned and structured and repetitive. And these are performed in collaboration between nurses and the occupational therapist, the physical therapist. You'll see that continued from the acute care setting down to the community-based like rehab centers and to the home care setting. So what are you working on with these patients? You're working anywhere from active range of motions, passive range of motion, to stretching, weightlifting, water exercise, gait training. And so you're working on multiple levels with these patients. When we talk about pharmacological agents, you're going to have multiple different categories that are used with these patients. Anti-inflammatory agents, they're commonly used. You'll see them will help with the um, the pain and then the inflammatory process. You'll see anywhere from corticosteroids to non-steroidal anti-inflammatory. So your Motrin kind of or ibuprofen, and you'll see also analgesics used in these patients. In addition to reduction of inflammation, you need some relief of discomfort. Your patient's going to be in pain. Also, a family of medication you will see used specifically with patients with musculoskeletal problems is muscle relaxants, and they provide relief of discomfort by releasing those skeletal muscle spasms. And you'll see also, like I said, supplements, and we need to add vitamin D and calcium because we're working on prevention and treatment of osteoporosis. And you see biphosphonates also. Um, and our goal here is to help slow or stop the reabsorption of calcium from the bone, and that way um, we're maintaining and improving bone density and strength. Um, the not last option, sometimes it's the first option because it's a curative versus palliative interventions that we've been doing. So surgical interventions, with a patient that has a knee problem, you're gonna have arthroplasty, arthrodesis, the patient with disc problem, you see discectomy, you see spinal fusion. And so, of course, when we talk about palliative, that's an example of amputation. And then you see the immobilizations. We talked about this a little bit, the cast, the splint, the braces. And what do you do when a patient has immobilization? And you're very careful about that complications of immobilization, but also about the skin breakdown from the use of these immobilization tools. And then assistive devices we talked about. There are other therapies that are used with when it comes to musculoskeletal and the pain. You'll see the TENS, transcutaneous electric nerve stimulation, is another therapeutic intervention where they use the low voltage electrical current to relieve pain. We talked about the interrelated concepts, so we're gonna dig really deep into them when we talk about each system and how they're interrelated, and then what happens, what's the effect of immobility on each level. Your exemplar for this semester is immobility in general, but as you move along in the program, you will have different exemplars in different levels of mature. So I know spinal cord injury is covered in the last semester, for example. Okay, that's it for this concept of mobility.